emergency consultants, and I usually like to start this talk with just a little bit of background about myself, which is, how I ended up here and how I ended up in ultrasound. So when I finished my emergency medicine training in New York in 2002, I was in the first class of, or technically the second class of trainees that had to demonstrate ultrasound proficiency before we could sit our exams, and it was kind of a joke because the people above us didn't really know anything, and so they couldn't really teach us anything, so we didn't really learn anything. And I kind of got out as a consultant. I'm working for a couple of years, and it got to the point where my trainees were coming to me with these like little thermal printouts, those little photographs that the old machines would give from ultrasound. And they would say, "Hey, Scott, what do you think of this? I think this person's got gallstones." And I would stare at this image and I would be saying to myself, they might have gallstones, or you might be actually showing me an aerial surveillance photo of Afghanistan right now, because I can't make heads or tails of this. And this light bulb went off and I realized, my God, I've just started my career and I'm already the old guy who doesn't know the new trick. And it was so apparent to me that ultrasound was going to be crucial for emergency medicine. I wasn't even thinking beyond emergency medicine at that point in time, that I decided a few years later to go back and do a one-year fellowship in just pure emergency ultrasound, which is ultrasounding pretty much everything. And that's how I ended up here, because they wanted to start sort of an ultrasound program here, and they wanted to bring in somebody who was fellowship trained. So anyway, this is my passion. So I refer to this as clinical ultrasound. That's kind of like the new term. However, basically you've probably seen or heard many of these terms before: emergency ultrasound, because we were the first ones to do it. That's how it sort of started. Bedside, focused, clinician performed. This one's obviously probably the most popular, point of care ultrasound. But the problem with the acronym of POCUS, it just leads to too many people goofing on you, like, "Hey, what is your hocus pocus show?" So this one, for various reasons, plus it's a big long word, is kind of going out of style, and clinical ultrasound is the new term that will hopefully be the final term. So what is clinical ultrasound? It is ultrasound that is actually brought to the patient, and it is performed by the providing clinician or a member of the treating team. The results are immediately interpreted and worked into the overall clinical picture. And it's not a replacement for a formal radiology scan by any means. However, sometimes we get beautiful images that you would never need to duplicate because they're that good. We've got a couple of good machines down there. But really, it's a really powerful extension of the physical exam. These are some of the things that we are looking for in the emergency department. And all of these various diagnoses have been extensively studied in the emergency medicine literature, and have been shown to be incredibly reliable findings on ultrasound, and are part of the most emergency medicine armamentariums. But ultimately what we have to do is to differentiate the undifferentiated, right? We get people who come off the street, they either can't speak or they can't speak English, and something horrible is happening to them, and we kind of have to rule out really bad things immediately. So our motto in the emergency medicine is worst first. And so ultrasound is a very useful way to help us get through that. For the most part, we are just answering simple yes or no questions. Does this old man with back pain have a AAA? Does this woman with a little bit of spotting have an ectopic pregnancy? Things like that. I like to start with a little bit of a history example, rather. I find this interesting. I'm into history. I was actually a history major when I was in college, way back in the day. This is the very first published description of the use of ultrasound by a non-imaging specialist in the English language. Because I'm a bit of a history geek, and because I'm an ultrasound geek, and probably because I'm a little bit of a stalker, I found this guy. He is still alive. In fact, he's practicing like airline medicine in Maui right now. So the gods have been good to him based on his sort of inventing focused or clinical ultrasound. But it's kind of an interesting story, and I'm just going to just tell it really briefly. This is him right here, Ray Marin. So he was a doctor in the Midwestern United States, and he had a friend in cardiology, and he found out they were throwing away their old echo machine, and he said, "Oh man, if you could just teach me how to find a pericardial effusion, that would be practice changing. And so they taught him to find a pericardial effusion. This is the actual machine right here. And here he is just doing a subxiphoid view of the looking for an effusion. And over a period of a year or two, he had 3 patients. This is just a case series of just 3 patients. 3 patients who came in with signs and symptoms of pericardial tamponade. Anybody know what that's called? Like physical signs and symptoms? There's a triad. Beck's triad, right. So 3 people came in with Beck's triad. Prior to the ultrasound, every one of them would have gotten the standard of care in the emergency department, which is a big long spinal needle attached to a huge syringe and a blind stick through your liver, hoping you might find some fluid to drain. And that's what you get, a blind pericardiocentesis. So thanks to the ultrasound, 2 of those people actually did need it. And he drained them successfully and stabilized them and got them to theater in time. But the 3rd one was actually having a massive PE, and that would have been incredibly harmful to stick a big needle into her heart. So this is actually the birth of clinical ultrasound right here. And just from a history perspective, I think I should mention Grace Rozicki. She is a trauma surgeon in Atlanta, Georgia. She published this paper in '93 in the Journal of Trauma about the use of ultrasound in the trauma room, and this is by use by the surgeons. So her question is, 1, is ultrasound useful in a trauma situation in the trauma room? And 2, can surgeons learn how to do it properly? And the answer to both those questions were yes. She called her exam the FAST, which is Focused Assessment Sonography for Trauma. Now, she was actually not the first person to suggest using ultrasound in a trauma situation. In fact, I believe that John Chambers in Dunedin, I don't know if any of you guys have rotated through there, he's the head of the ED, I think he's retiring soon. I think he was the very first one to write a paper on this in the 70s. But she came up with the cute, fancy double entendre acronym, so she goes down in history as like the inventor of the FAST exam. A little more history. This guy's interesting, Daniel Lichtenstein. He's still a practicing critical care guy in France. And he started playing around with ultrasound in the chest, which to any imaging specialist, they would just sort of laugh at you. That was folly. How could you possibly see anything in the chest? Because air is the enemy of ultrasound. So as soon as the sound wave hits air, it just scatters and creates artifact, and everything from that layer down is just all fake news. Why would you be looking in the chest? Well, it turns out that these artifacts of ultrasound, things that aren't really there, their presence or absence on the screen are diagnostic of some conditions. And so he was the first one to describe pneumothorax in ultrasound, pneumonia, this wet lung, which is basically like fluid in your interstitial or alveolar space, so CHF, ARDS, pulmonary edema. And so he got pretty famous off of this and has written textbooks, and he tours and gives talks, and I would highly recommend, if he's ever in town, he was a couple years ago, to see his talk. So here's a little bit more of the history of clinical ultrasound. In '97 in the States, the first emergency ultrasound fellowship was created. This is something like I did. It's like a 1-year thing. In 2001, the American College of Emergency Physicians said, you must be teaching this and you must demonstrate proficiency, otherwise we're not going to accredit you as a teaching institution any longer. In 2006, the University of South Carolina became the first in the world to offer a full, so medical school in the States, as you probably know, is a postgraduate thing, so it's 4 years. So this was the first to offer a full 4-year vertical curriculum in ultrasound. So these students show up on day 1, they get their little white coats, their stethoscopes, and their portable ultrasound machine. And by the time they graduate, even the future psychiatrists are proficient in ultrasound. This was quite a revolutionary thing. It's another interesting story, but I'll just briefly tell you where this light bulb moment came. The dean of this school was a rheumatologist, actually, the dean of the medical school, and he was in one of his EDs in the early 2000s, I think with a friend or something, and he noticed the emergency doctors going around with ultrasound machines, and he had never seen that. He wasn't aware of it as a thing, and he asked a couple of questions, and suddenly, boom, this light bulb went off. He's like, well, if the emergency doctors, if this is really useful for them as a diagnostic or physical exam device, well, then we should be teaching this to medical students. Like, why start in specialty training? Everybody should know this. And he was absolutely right. So that was the first one. They're all over now. closer to home, this is actually very significant. So you may have heard of this. University of Otago has a 1-year diploma, postgraduate diploma in clinician-performed ultrasound. They always have a waiting list. It started out for rural GPs only, and now it kind of includes everybody. I know a lot of people who have gone through this. But this is a first of its kind in the world, actually. In fact, in the United States, you cannot get, there is no qualification you can get unless you're a radiologist in ultrasound training. I had to take the sonographer and echocardiographer exams to get some letters after my name, but that's all there was. This is sort of like a diploma specifically for physicians, and so that's pretty cool. 2007, GE invented the very first handheld device, called the V-scan. 2008, some more emergency medicine colleges required ultrasound training. 2011, the British got on board. 2012, this paper came out in the New England Journal of Medicine, and it's a simple review paper called Point of Care Ultrasonography. But the significance of it is that if you know anything about the New England Journal, when they publish your paper, you are getting the official seal of approval from the medical establishment. Up until this point in time, and even afterwards, there were tremendous political battles, as you can imagine, over the use of ultrasound outside of a radiology department, outside of a cardiology department. So a lot of major, very ugly turf battles that I've been a part of myself. And so this was kind of our we're here, we scan, get used to it statement, and it's been tremendously helpful. So Chris Moore's conclusion was that the use of point-of-care ultrasound is going to just go through all specialties, and he has been correct about that. So here, just locally, it became a requirement in emergency medicine over here only recently. Now the College of Intensive Care, these are mandatory requirements. And there are other colleges that have small mandatory requirements. I don't want to get too deep into that. Just know that all of these schools, colleges in Australasia have ultrasound in their curriculum or required to some degree. So virtually everybody is using it, and it's in virtually everybody's training curriculum. It will definitely be coming to general medicine and definitely be coming to family medicine. It already is in the United States. So let me just show you how we find this useful in our department with an example. Okay, so 61-year-old lady. I actually took this handover on this woman. I came in at 5 p.m. and the story was 65-year-old woman. She ate some dodgy chicken out of her refrigerator. It was old. And then a short while later developed severe vomiting and diarrhea, just like massive vomiting and diarrhea. So she's got food poisoning, and plan is we're going to put her in EDOU, our observation unit, make her feel better, and discharge her in the morning. I was like, great, that's fine. All of her vital signs were normal. So at some point in time, the nurse calls me and she says, how much fluid do you want me to give this woman? And I said, well, I don't know, what's charted? And she said, well, what's charted is run out, and I just don't know how much fluid she's lost because of all the blood. And I said, blood? Nobody said anything about blood. How much blood does she have? I don't know, it's just filled the toilet bowl, but how much fluid do you want me to give? And I thought, all right, let me go and see this woman. And there she is. She's sitting there with like a little hottie, totally normal vitals, little hottie on her belly, and with her eyes closed. And I go and I touch her abdomen, and it's like, So she had now developed an acute abdomen with massive bloody diarrhea that started out as vomiting and diarrhea. So my thought was, okay, she's got some kind of bad colitis. Could be ischemic colitis, could be something. She's clearly going to the surgeons. And I just want to make sure she didn't like perf a bowel. So I just sent her for an x-ray, because now it's like 9 o'clock at night. And they stood her up for the x-ray, and then all of a sudden she had what looked like a stroke. Okay, she left side of the body, left facial droop, left arm went down. She became kind of unresponsive, was foaming at the mouth. They quickly threw her on a stretcher, wheeled her into the recess room, and her blood pressure is like 70, maybe systolic, and it had just been 120. And so it was very confusing because I was just had my head wrapped around, okay, she's got bad colitis, and now she's having a stroke. Like, I was very confused for a brief moment in time. And as I'm thinking about ordering a head CT for her, I grabbed the ultrasound machine just to have a look inside of her abdomen really quickly, and this is what I saw. Okay, liver, IVC, aorta. Anybody see anything abnormal there? I'll give you a hint. It's not in the liver or the IVC. See this line right here? This is a cross-section of the aorta. That is an intimal flap, okay? So within 1 second, so I've got this woman with gastroenteritis who may be having a stroke. Within 1 second, I know, okay, she has an aortic dissection. It involves her abdominal aorta. And then 2 seconds later, I thought, okay, that makes sense. It must involve her mesenteric or celiac artery as well, and she's got some gut ischemia. This is all making sense. Why is her blood pressure so low? And I even thought, okay, maybe it went up her carotid and gave her a stroke, because that's a common thing. So then I just had a quick look at her heart, and this is what I saw. So here's left ventricle. This is a peristernal long axis view. Left ventricle, this is right ventricle right here, and here's the mitral valve. And right up here, this black stuff is fluid, so that's a pericardial effusion. Let's see if I measured this. Yeah, so, and here is her aortic root. I wouldn't expect you to be able to identify that, but you just have to trust me. It was 5.3 centimeters. Anybody know what the definition of aneurysmal is in the thoracic aorta? It's different from the abdominal. Abdominal aorta, if it's 3 centimeters or more, it's an aneurysm. Anybody know about the chest? 4. 4 is, anything above 4 is considered aneurysmal. So this is well into the aneurysmal range, okay? You'll notice here that this is mitral valve. The mitral valve is open right now. So we are in diastole, all right? And this is her right ventricle, and this is the outer wall of the right ventricle. And you see how it's completely bent down like this? So it's totally, I don't know if you can appreciate that. You see this scalloped appearance? It should be going up, and it's going down. It's concave, it should be convex, all right? So anyone know what that is called? Tamponade, right, exactly. So within literally 2 minutes, this woman went from food poisoning, bad colitis, to I already know she has a type A dissection. That's where you dissect at the root, and the significance of that is it's operable. I know she's got a type A dissection that goes all the way down her abdomen, probably involves the arteries that feed her gut, and she's got tamponade right now. And she's like actively, she'll be dead in 15 minutes with no intervention. But that is how powerful this ultrasound is. And that was just a couple months ago. It was a recent case. I'll just go over, I got a bunch of cases I just want to go through here. Here's another way it's sort of useful. This is a guy, an older guy. One of my colleagues was seeing at nearly 2 o'clock in the morning, trying to sort out. He was an older guy. He had sort of back pain and abdominal pain and some weight loss and some urinary symptoms. And so the question is, okay, is this a urologic problem? Is it a ortho problem? Is it a general surgery problem? Like, we just kind of have to get to the bottom of this. And so she just took out this scan and had a look at his kidney, and you'll see this is the kidney here, and this black stuff is all fluid. So that's hydronephrosis on the right side. That's weird. Didn't seem like a renal colic story, but so then she decides to have a look at his other kidney, and here's the other kidney. Looks exactly the same, big dilated renal pelvis and calyces going down into a dilated ureter. So now he's got bilateral hydronephrosis. Where's the next place you want to look? Boom, bladder. So here's his bladder. Black is fluid on ultrasound, and there's this gigantic bladder mass right here. So, it's not great news for the guy, but from our point of view, we were able to very efficiently come up with what was wrong with this guy with incredibly vague symptoms and get him into the right hands quickly without a lot of screwing around. Okay, I know you guys are way better at this stuff than I am. Anybody know what this is? Who can definitively look at that and say, I know what that is? Now, I can't, because I haven't picked up an ophthalmoscope since probably the late 90s, except when the otoscope battery is dead and it's the only torch I can have, and I need to look in someone's throat. That's what it's useful for me. I'm not supposed to say that out loud to you guys, but okay. Anyone definitively know what this is? They all could be. What else could it be? Why do you say retinal detachment? This thing here? Maybe that's what retinal detachment looks like, right? Okay, you are correct. It is retinal detachment, but which is more definitive? This is an eyeball right here. This is the ripped off retina. This black line at the bottom is the optic nerve. And so this torn off retina does not cross the black line at the bottom. It doesn't cross the optic nerve. That's how you know it's a retinal detachment versus a vitreous detachment. So, I mean, decide for yourself. Which would you rather use as a tool to make that diagnosis? Right? Not to mention, I took this off of Google. They could have been lying to me when I just Googled in retinal detachment. This could be anything, because I just don't know what these things look like. But like, you've got to dilate their eye for this, and you got to have, you know, proper equipment. And any ultrasound machine can get you that picture. Here's another one. This is what a posterior vitreous detachment looks like. According to Google, this is what it looks like on fundoscopy. But here you'll notice this white line at the bottom, and it does cross the midline. It does cross the optic nerve. And then there's just like some junk floating around in there. That's a little hemorrhage and posterior vitreous detachment. Much less serious than a retinal detachment, but just as easy to diagnose with ultrasound. We use this all the time, abscess or cellulitis, okay? So this image here, we have the white stuff. These are like fat lobules, and the black lines are fluid going in and out. So this is we call this cobblestoning, but it's a very non-specific sign for fluid in between your fat lobules. You can see it in infection, you can see it in peripheral edema. Here is what an abscess looks like. It's unmistakable, it's beautiful. You can measure how deep it is and how wide it is and see if there's any vessels nearby and cut it open if you want to. Here's a guy, a 29-year-old guy who came in with right upper quadrant pain. He was a direct referral, I think from Kenny, Peru, to the surgeons. And one of my registrars went to just have a look at his gallbladder. And as soon as he laid the guy down, he noticed that he was short of breath, and the gallbladder and the liver kind of looked fine. And so he immediately went up to his chest. So what we're seeing here is this white line going back and forth, that's pleura. And because beneath the pleura is air, everything from the pleural line down is an artifact. So fake news from here down. But you see these big, bright searchlights coming off of the pleura. Does anybody know what those are called? That's an artifact of ultrasound that French guy, Daniel Lichtenstein, invented or discovered. These are called B lines. Sometimes they're called lung rockets, and it's a sign of interstitial fluid. Okay, so this is a guy with fluid on one side. He actually had this on both sides. So he basically has pulmonary edema. It could be non-cardiogenic. We don't know what it is exactly. All you have to do is move the probe down to his heart, and here is his heart. And look at this left ventricle. The black stuff is blood, okay? You don't have to be a cardiologist to estimate, okay, every time this heart squeezes, what percentage of that black stuff is leaving the chamber? What would you guys say? And that's his ejection fraction. What would you say? How much of this black stuff is leaving? 10%, yeah. That's all you need to know. This is a new diagnosis of a dilated cardiomyopathy in a previously healthy person who basically needs a heart transplant. I mean, he's a completely useless heart. Why did he come in with right upper quadrant pain? It's related to this. So if the left heart's working, then the right heart, or if the left heart is not, the right heart is not either. So everything's just backing up down into his liver, basically. So he had hepatic congestion. That was what brought him to us. I mean, so it was a good thing my guy scanned him. Here's a case from, I don't know, a couple weeks ago. 75-year-old lady came in by ambulance. She swerved off the road. She had stroke symptoms. Stroke team was called. She gets to CT, then she becomes more, they don't really see anything in her CT. She becomes more agitated. Her GCS drops. She actually has to get intubated, and one of my colleagues did this scan of her chest, and aortic root, number 4 is too big. This is again 5, and here is a subxiphoid view of her heart. All right, so this is liver, this is obviously heart, this is dilated aortic root, and can you guys see this little flap in here? See something? That's not valve. A valve is like open, close, open, close. This thing is just flapping around. Okay, so she technically was having a stroke because it did go up her carotids, but it was from an aortic dissection. And so if aortic dissection seems like the theme of this talk, it should be the theme of your thought process in the department. It's what we live in fear of every day. They never, ever come in the way they're described in a textbook. They always come in with something weird like this, and you always have to be thinking about it. And we get them, I think we average over 1 a month. So they really do come in fairly more commonly than you thought. And again, here's her abdominal aorta, and you can see the flap going through it right there. And here's a long axis view of the aorta. Same thing, there's the flap right there. And here it is on CT. You can see this big crazy flap. And then here's the descending aorta with the true lumen and the false lumen. Here's a guy who came in with fever and shortness of breath, and he's got this chest x-ray, okay? He's admitted to medicine already. He's still in the emergency department for pneumonia. And you guys can see the bilateral infiltrates here. And one of my registrars came to me and said, you know, something's not quite right about this. She was really good of her. Like, I'm not convinced this is pneumonia. Can you just have a look at his heart? He had no cardiac history whatsoever. So I went and did an echo of him. And here's just a two-chamber view, left atrium, left ventricle. Anybody see anything abnormal? This is the mitral valve right here. So you just got two views, or two-chamber view here. What's that? So regurg, yeah, there definitely will be regurg. You can't say there's regurg until you actually put a box on it, color box, and you watch it kind of go backwards. But if you notice, have a look at this. This is the posterior leaflet of the mitral valve right here. This is what we call a flail mitral leaflet, okay? It's basically his papillary muscle just popped, and now this leaflet is just useless. And this is a previously normal heart. And actually, I sort of froze it right here in this one section. Like, look at that. There's this, so every time his heart squeezes, half of the blood's going out the aorta, half of it's going back into his lungs. So he had a fever from his inflammatory response from his ruptured papillary muscle. So that was a good pickup on my registrar, and he went to the theater instead of going to the medical ward with his pneumonia. This was a very busy night in the ED, and all 3 recess rooms are booked, and each patient is sicker than the next in those 3 recess rooms, and it's midnight, and this is the least sick of the 3 patients. But the question here was, this lady, does she have CHF? Does she have pneumonia? Does she have COPD? What's going on here? Let's see if you guys can tell me what's going on here. This woman needs a medication immediately. Yes, look at her right atrium. You see that thing spinning around in there? That's a giant clot. So first of all, her right atrium's huge. It should be 60% the size of the right ventricle rather. Should be 60% the size of the left ventricle. It's way bigger than the left ventricle. And there's this clot spinning around in here. So she's already chucked off a whole bunch of clots to dilate her heart that big. This is what we call right heart strain. When the right heart gets dilated like that, it's because it's trying to squeeze blood forward, but there's a clot in the way, so it kind of just backs up the right heart and it gets strained. So these are the people who need thrombolysis. Good. Okay, we do see some happy things in the ED. What are we looking at here? Yeah, live baby? Yes, exactly. So you can see a little baby here and the heartbeat. Only problem is, this is a fallopian tube. So you can be fooled. It's amazing how thick the tube can get when you have a tubal ectopic. But this is someone who came in who could easily, this could have been missed by someone who didn't know what they were doing. But yeah, that's a tubal ectopic, unfortunately. And it was already starting to rupture. This is, this black stripe here is a little bit of free fluid in her right upper quadrant. That's liver and kidney, so this is Morrison's pouch. We do a quick fast exam. So for us to be able to even see a little bit there, she's probably got about 500 mils of blood, rather, in her abdominal cavity. We do all sorts of cool stuff. Fracture reduction in kids. This is really useful. So you do the reduction, or whoever does the reduction, and oftentimes they have to go to x-ray and it's not quite right, and then they come back and forth and back and forth, and you want to be able to plaster them definitively. But look how well bone shows up on x-ray, and anybody can tell there is a broken bone right there, right? So that's before the reduction, same person after the reduction, and that's the break right there. It's perfect. Cast them. We don't have to faff around. Here's somebody you'll see every Friday and Saturday night if you work in our department. Somebody who was beaten up, got into a fight, whatever, bottled in a bar, but their eye is so swollen you can't actually examine it. So some basic things you want to know. If you can't assess their acuity by opening their eye, you want to know what? What else do you want to know? What are like basic things you want to know about an eyeball besides acuity? Photophobia. Okay, photophobia, right? What else? Pupillary, yep. What's that? Okay, hemorrhage, and actually you can see hemorrhage nicely in ultrasound, and extraocular muscles. So one of the cool things you can do with ultrasound is this is a closed eye right here. But if you ask them, move your eye from side to side, you can see it on ultrasound. And then you turn the probe 90 degrees and have them move it up and down, same thing, and you could just say grossly their extraocular muscles are intact, okay? So same person, now you put the probe on their bad eye and you shine a light in their good eye and you can watch their pupil react, okay, through the consensual pupillary reflex. So very useful. This is a 1 a.m. guy who his story was he was having a nightmare and woke up and put his hand through the window that was right next to him. He had a laceration right here on his wrist. It's about 2 centimeters, and his neurovascular exam was normal. And the question is, we always send him for an X-ray. You know, is there glass there? Who knows? So what do you do with a guy like this? He's got a wound. Everything is intact. He may have a tiny little piece of glass there, or maybe not. Do you dig for it and possibly cause more harm than good? Do you just turf it to orthopedics and make it their problem? Send him home and say you'd be fine? There's only one right answer to this, and I haven't given you it yet, and it's obviously ultrasound. So have a look at this. This is a long axis view of his radial artery. You see that there? That is glass. That is a hole in one. This tiny piece of glass went through his skin, through one wall of the radial artery, and then stopped, completely encased within the radial artery. And look how beautifully it shows up on ultrasound compared to that X-ray. And that little clot hanging off of it, and this is actually a pseudoaneurysm, so blood is kind of gushing up here. And look how small this piece of glass is. It's tiny. I mean, if you're trying to dig for that in soft tissues, it would be impossible to find. And the reason why he had a normal vascular exam is because you can see, here's the glass right here, but blood is getting around it and getting to the hand. So he's well perfused, he's got a radial pulse, or actually he's got a pseudoaneurysm that feels like a radial pulse right here. You see this is blood going up into the pseudoaneurysm. So anyway, this guy went to theater and had his radial artery opened and that glass removed. This is where ultrasound is really helpful in undifferentiated patients. This guy came in again like 1 o'clock in the morning, code 2, 50-something-year-old guy, just absolute agony, like couldn't speak, couldn't lie on his back, couldn't do anything. He was in so much pain that came on suddenly. And so the thought is, oh my God, is this a dissection? Is this a ruptured AAA? Is this, what the hell is this? So one of my registrars who took this image is kind of like all you could do, because you can't even examine him. All you can do is sort of have a quick look inside, see if something weird jumps out at you. And this is his left upper quadrant right here. So this bottom piece is spleen. This is kidney. Black is fluid on ultrasound. And what do you guys see there? This gray stuff, this smoky stuff, that is new fluid coming into this black stuff here. And then all this white, weird looking stuff is clot. So that is like a live picture of a ruptured splenic artery aneurysm actively bleeding into this person's abdomen. So again, guy screaming in agony, code 2, can't speak to you, and in 5 seconds we know what's wrong with him, and it's critical. Here's a guy who also came in recently. He was Malaysi. He had cardiac sarcoid. A month ago he had an internal defibrillator placed, and he just was like malaise. That was his chief complaint. A nursing student sat him up in bed, and he had one of those like really intense syncopes that looks a lot like a seizure, where he was stiff and foaming at the mouth, and his blood pressure dropped, and it was like, it was very dramatic. And even for I watched it, even for a couple seconds, I was thinking, is that a seizure, or is that, this is really weird. But his blood pressure was so low that when we lowered his bed, he came around, he wasn't postictal. But of course, immediately, we went to his heart. And so once again, we have right ventricle, left ventricle, and here's his pericardial effusion, all right? And if you look at the wall of the right ventricle here, it's subtle, but it's kind of bouncing around a little bit too much. And here's the money shot right here. You guys see this? Any guess what his diagnosis is now? Yeah. So his defib wire is punctured through his ventricle. So he's basically like, it's like a stab in the heart, and he's bleeding around it. And here is the shot once again in diastole. I've got mitral valve open here, and you look at the right ventricle, and it's concave. It's getting squished. So this was tamponade again, and this was from his, defib wire. So speaking of tamponade, I'm going to move on a little bit here. Claude Beck was a cardiothoracic surgeon in the United States a long time ago. He invented the internal defibrillator. I don't know if you guys have ever gone into cardiothoracic surgeries or been in an ED where they've done an open thoracotomy on somebody. But these are those, they look like cattle prods and these long like metal things, and you actually touch them to the heart and go zzz, and that's what they do in theater, because you can't obviously put pads on somebody whose chest is wide open, right? So he invented that thing, and in 1947 he was operating on a teenager with some sort of heart problem, and the kid went into cardiac arrest, and he's sitting there squeezing the heart and not getting anywhere. And he finally said to someone, in the boot of my car, I've got this thing that I invented, but this kid's dying, I might as well try it. So someone continued the compressions. He went out to his car, got his internal defibrillator, used it, and apparently brought the kid back to life. And that was a great invention. He invented the internal defibrillator and was the first one to use it experimentally and successfully. Unfortunately, Claude Beck is known more for this, Beck's triad, which they teach you in medical school. And that's great, learn it, because it'll be on an exam somewhere. But it was long ago debunked as anything useful. In fact, somebody even recently looked at it, I think this was 2017, and basically found it had 0% sensitivity. So it's just one of those dumb things you have to learn in med school, and you can forget about when you choose. But just get through the exams. Now, this is really an interesting thing, particularly for you medical students. Again, I want you to get through whatever exams you have to take and learn what they're teaching you, and then you can start rethinking what you've been taught. And this is a great resource to help you think what you've been retaught. So this is put out by JAMA. It's downloadable. It's about $40 on a Kindle or something, or your iPad. And it is an evidence-based look at all of the physical exam signs they teach you in med school, like the fluid wave and jugular venous distension and things like that. And it shows you how useful or useless they actually are in real life. And I don't want to bias you too much, but a lot of what you learn, as you will learn, is unbelievably useless. And I might as well just start with the jugular veins. Let me just go off on a quick little tangent here. Please tell people about their jugular veins when you're talking to a consultant, but it's okay if you don't mention it if you're talking to me. So what are descended jugular veins? They are a surrogate for central venous pressure, okay? They're not central venous pressure, they're just a surrogate for it. Central venous pressure, I don't know why these academics haven't caught on yet, was debunked at least 12 years ago as a parameter that is of any use in any situation whatsoever. So like they don't measure it in the ICU anymore, it's not used. And so if central venous pressure is useless, how useless is a surrogate for central venous pressure? I don't care. So anyway, speaking of useless things, happy birthday stethoscope. 203 years old, largely unchanged since it came out of Claude Lenec's laboratory in 1816. So useless that even the lay press is asking about it, okay? So here's something in the New Zealand Herald a couple years ago. The development of ultrasound, of pocket-sized ultrasounds are raising questions about why doctors continue slinging earphones and rubber tubing around their neck. This is last month in Time magazine. Basically, same story. The stethoscope is dying. Within the next decade, handheld ultrasound devices will become a part of the routine physical exam, and that's 100% correct. When I put up this slide, I personally just get this quick moment of PTSD because I had to memorize this stuff. I never understood any of it at all. I think I memorized it enough to get through an exam, but look how complicated this is. Like, this stuff is probably somewhat familiar to you. You've seen this. Surely you've seen some form of this recently and been asked to make some sense out of it, right? Okay, I got to move on. Here is a study that looked at really how good are we at doing auscultatory exams. And this was done in the States. So they looked at medical students, residents, cardiology fellows, general physicians, and GPs. Okay, so the cardiology fellows were the best, but the second best people auscultating were the third-year medical students, because those are the ones who have just been sitting there like listening to those tapes of crescendo, decrescendo, this, you know, all that nonsense they teach you. Anyway, interesting study. Here's another one I like too. This is published in a cardiology journal by a cardiologist. So they took first-year medical students and taught them how to do a basic echo, and then they had fully qualified cardiologists using stethoscopes and their hands and ask the two questions: are there significant valve lesions in these patients? And they all use the same patients, obviously. And what is their estimated left ventricular function? Okay, so the first-year medical students were pretty damn good, and look at the cardiologists. All right. So this is not a knock on cardiologists. This is a knock on the stethoscope, because the cardiologists are the best amongst us. But if a cardiologist is 50% on a significant valve lesion, I'm not talking about an innocent murmur, a significant valve lesion, if they're going to miss it 50% of the time, then who am I to even bother trying to listen or make sense out of that chart, particularly now that I have ultrasound. So like, look at this heart, for example. The blue jet that you see right here is mitral regurg, okay? Every time the heart squeezes, there's a blue jet coming back. This is the tricuspid valve. Over here, you also see a blue jet coming back every time the heart squeezes. So this person has mitral regurg and tricuspid regurg, and then you see this red bit that's dribbling out every time the heart relaxes. That's aortic regurg. Now really, who amongst us could put a stethoscope on a person and say definitively, this person has moderate mitral and tricuspid regurg and a little bit of aortic regurg? No, of course not. You put an ultrasound probe on them and turn on the color box, and your answer is right there, staring you in the face. Like, there's no more guesswork. Yeah, maybe it's a cool trick. If you're so good at a stethoscope, you can get it right better than 50% of the time, but why even try when you have this technology? So this is true. I assume I'm not offending anybody in this room with this slide right here. Nobody's from Mississippi or wears a Trump hat. Anybody? So all medical students in the States are learning ultrasound now, to some degree, every medical school. And I don't want this to seem like this is like this American-centric talk, because actually this all began in Germany, apparently. They started using it in a limited way in 1996. There is a Society for Ultrasound in Medical Education. So this is a group of academics, of ultrasound people, of scientists who've all gotten together and said, okay, well, we've got to put ultrasound, we've got to get it into the medical student curriculum. Who's got some good ideas, and they've kind of, they have these conferences every year. But according to this website, ultrasound is being taught in medical schools in all of these countries. Now, not all the medical schools, and might not be a 4-year thing like South Carolina, but this list is something like close to 20 countries long, and that was like the last time I looked at it. This is a statement from the European Federation Society of Ultrasound. We have an organization over here like that called the Australasian Society for Ultrasound. It's just, again, doctors, scientists, sonographers, and people who are into ultrasound. They basically said ultrasound needs to be a part of the undergraduate medical curriculum for everybody. And this is why it's going to happen. I'm sure, is there anybody in this room who hasn't heard of this device yet? Yeah, okay. Oh, great. I have one in my backpack. I can show you. So this is a huge game changer. It just came out in 2018. First of all, the price, $4,000 compared to that GE device that I showed you, which was about, last I checked, $12,000, $14,000. Number two, this only uses one probe. They completely redid the technology. I don't even know how it works. It uses a chip. It doesn't use the vibrating crystals like traditional ultrasound. So you only have one probe, hooks up to your iPhone, gets pretty good images, and it's $4,000. And this is going to be the new stethoscope, no doubt about it. I mean, it is already to many people. So I put that out there. And I would like to finish with a lesson in history. So Louis Conner was the founder of the American Heart Association, and he was the most prominent cardiologist in the United States during his era. Despite that, and despite the fact that he was born 50 years after the invention of the stethoscope, he was born then, he thought that the stethoscope was just some sort of gimmick. And he never trusted it, never believed it, and refused to adopt it, and basically finished his career auscultating hearts. This is the most famous cardiologist of his day, auscultating hearts the old-fashioned way. That's literally what he did. He would put a towel down and stick his ear to the person's chest. Okay, so the message is don't be Louis Conner, and don't be bummed out that you did not get ultrasound in your medical education, okay? I learned it as a consultant, and most people will learn it that way. There are so many opportunities to learn ultrasound, and it's just gonna keep getting bigger and bigger and bigger. And like I said, no matter what specialty you go into. So we do a lot of ultrasounding, as you'll see. We have 3 machines. I want every one of you to have your hands on that machine at some point in time with one of us, just getting a feel of it to see what things look like and to see how easy it can be. And along the way, I would encourage you to take up as many opportunities to learn ultrasound as you can. There are paid courses that you can go to. There's all sorts of online stuff, and it definitely can be done. It may have to happen over a period of years, but this is your future. There's no doubt about it. If you don't learn this, you're going to be sort of like me. You're going to be the young dog who didn't learn the new trick, and it's too late. So, although it's never too late. Anyway, so my purpose here is to get you guys psyched up about ultrasound. Hopefully I've done that. And I think next we're going to actually teach you how to do the FAST exam.